Días, good morning, buen día. Comenzamos en unos momentos mientras
We
todos.
will begin shortly while we wait for everyone else to join.
We have translation in Spanish, Portuguese, and English. So please use the interpretation button at the bottom of your screen, and you can choose the language of your choice. Para traducción pueden ir al botón de interpretación y escoger su idioma. We will start in a few moments. Okay, we will start. We have already 460 persons connected. So let's start with the opening remarks. So the Pan American Health Organization is pleased to welcome all of you to this webinar. When we take the opportunity to join the global campaign led by the World Alliance for Breastfeeding Action. This year's PAHO's campaign theme is Let's Make Breastfeeding and Work Work. The campaign centers around enabling breastfeeding and making a difference for working parents. The objectives of the current workshop are to inform people about working parents' perspectives on breastfeeding and parenting, anchor optimal paid leave and workplace support as important tools to enable breastfeeding, engage with individuals and organizations to enhance collaboration and support for breastfeeding at work, galvanize action on improving working conditions and relevant support for breastfeeding. PAHO's campaign this year focuses on enabling breastfeeding in the workplace. More than 500,000 women a worldwide lack of adequate maternity protection, and millions of women in the informal sector lack access to critical maternity facilities. Just 20% of countries require employers to provide employees with paid breaks and facilities for breastfeeding or expressing milk. And fewer than half of infants under 6 months of age are exclusively breastfed. As we know, breastfeeding provides vital health and nutritional benefits for children, with positive lifelong impact. All children should benefit from this practice, regardless of the working conditions of their parents. They shouldn't have to choose between breastfeeding and their jobs. The World Health Organization recommends that babies be exclusively breastfed for 6 months of life, followed by introduction of nutritionally adequate and safe complementary foods, and with continued breastfeeding up to 2 years old or beyond. Supporting working parents to follow these recommendations requires adequate maternity leave, a minimum of 18 weeks and ideally more than 6 months, as stated by the International Labour Organization Convention 183 and Recommendation 191. A breastfeeding room at the workplace with accommodation for breastfeeding as well as expression and storage of breast milk, and reduced hours of flexible schedule while breastfeeding, since the ILO Convention 183 provides a woman the right to 1 or more daily breaks or a daily reduction of hours of work to breastfeed her child. We call for the different actors and sectors, including policymakers, employers, and colleagues, to support working parents by actions within their reach. In this webinar, we will share the situation of the facilitating factors for working parents in the region. We will also be able to listen to some countries describe their experiences in following ILO recommendations to improve the conditions of working parents. Again, welcome to today's World Feeding Week webinar. So welcome again. As I mentioned, we have simultaneous translation. Use the interpretation button at the screen. Tenemos traducción simultánea. Pueden usar el botón de interpretación abajo en la pantalla.
For simultaneous interpretation, you can use the interpretation button at the on the bottom of the screen, and we will have presentations and then some Q&A time. We will begin with some presentations from our colleagues at PAHO, followed by some experience from our countries and non-governmental organizations. Without further ado, we're going to give the floor to Dr. Ignacio Ibarra, who is an advisor on health legislation, and he's going to talk about mothers' right to breastfeeding. If you have any questions, you can use the Q&A icon in Zoom, and we will be answering the questions throughout the event, and also at the end, we're going to have some Q&A time, but please post any questions that you may have on the Q&A section. Ignacio, once again, thank you so much for being here, and go ahead. Thank you, Leo. Good morning, and good morning to all of you who are joining us today. For me, it's a pleasure to be able to be part of this webinar, because every day I get more and more convinced that one of the best ways of being able to achieve changes and make our countries more solid and richer is to focus our work on those who matter. We are all equal, we're all important, but the future generations need special work, the work of being parents. And if we give our children, newborn babies, the possibility for them to have everything they need, they will develop easily to become the best versions of themselves and will be a great investment in the future. I am here to talk about rights, and I believe that one of the first rights is the right to health. The right to health is a human right that's enshrined in international conventions, more specifically the International Covenant on Economic, Social, and Cultural Rights, which says that the state parties, which are pretty much all countries in the world, but for sure all the countries in the Americas, recognize the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. Now, there's a portion that sometimes we overlook on this international covenant, and that is a guide that has 4 steps that are 4 main elements that all countries must implement in order to attain that right to health to the fullest extent possible. And the first one is to reduce maternal mortality. In addition to that, we need to foster the healthy development of the child. Just like we are going to discuss today, the most important aspect that needs to be developed or encouraged, not necessarily as a right to work, but as the rights of the children, is the right to breastfeed. And that is why the second right is the best interest of the child, which is enshrined in the Convention on the Rights of the Child, which says that all countries and all legislative bodies, all institutions, companies, government institutions, because international agreements cover those as well, must always, above any and all rights, have to look for the best interest of the child. So, like Leo was saying earlier, the International Labor Organization acknowledged as a labor right for pregnant women or mothers that have newborns have this right that is legally recognized. ILO Convention 183 on maternity protection is also a human right, because this is an international instrument that all countries in the world have signed, and it also focuses on some conditions that must be included in labor legislation. This means that there is a right to mothers that aims at protecting both mothers as well as the child, which means that in the workplace there are also rights that are aimed at children. And like I said, Article 3 talks about the right to health protection. And for that, countries in their legislation and in consultation with all trade unions and employers ensure that pregnant or breastfeeding women are not obliged to perform work which has been determined to be prejudicial to the health of the mother or the child, or that they're faced with significant risk to the mother's health or that of her child. This is very important for the mother, because promoting breastfeeding is linked to the right to health protection, which is the underpinning of labor work. So employers are required to ensure these rights. So these rights are given to the mother, but the beneficiaries of that are the children. So we also had to provide required maternity leave. And in this, we need to have two things in mind. Countries have to include at least a period of 14 weeks of paid work. And the second thing is that there has to be a period of 6 weeks compulsory leave after childbirth. And this is not a labor right. It is because it is included in this ILO convention, but it is enshrined in labor legislation in the countries, but aims at protecting and promoting the health of babies. Leo talked about 18 weeks of maternity leave, which are also recognized by WHO in one of its recommendations. So it has to be at least 14 weeks. And what we are promoting is to make it last up to 18 weeks in order to have full consistency with this vision of protecting those initial days in the life of a baby so that they can achieve their highest potential. The benefits obviously include full pay. So the convention, ILO Convention 183, states that women have to be receiving at least 2/3 of their pay. But the recommendation that most countries are following is to have full pay. You're going to see this in their slides, but this is just for you to have an idea. Now we want to give you an overview of the situation in countries of the Americas. I'm sure the colleagues that will come after me will give you more detail. You will have this presentation so you can look at it closer later. But 22 countries in the Americas are yet to reach that compulsory 14-week period, which means that there's still a lot to do. There are 11 countries that provide those 14 weeks plus additional weeks. And I believe that only one or two have a little bit more. I know we don't have enough time for this, but I wanted to highlight that Suriname is a very interesting case. In Finland, maternity leave is mandatory for 7 months. 7 months, where both mother and father can use this required maternity leave with full pay. And this is not because it's a very advanced country, but rather because they are investing in the future of their country. So the moment this time investment by the government, employers, workers, mostly the colleagues of these people that are going through this wonderful period in their life when they welcome a baby to their lives, can allow for the bonding to occur so that those children can develop to their fullest extent possible. And so that is a snapshot of the situation for each country. And this is different in where maternity leave, only accounts for women's leave, but 16 countries in the Americas also give paternity leave. And this is a list of the situation. Some countries give up to 14 days to the father. And here, and a side note, we have seen that even though the legislation provides for this right, fathers do not use this time, which renders it pretty much useless. The other rights are the economic benefits or of keeping their job with full benefits. It includes, they can accrue vacation time, full health coverage, but also employment protection and protection against non-discrimination, which means that if I take maternity leave, when I go back to work, my job has to be there. And women may not be discriminated against for a job if they're pregnant. And to conclude my presentation, ILO Convention 183 also mentions as one of the rights to development of our children, and also as an employer's obligation and the right of working mothers to have breaks, daily breaks, in order to be able to breastfeed their children, and even to have reduced working hours in order for them to be able to breastfeed their child. This can be either throughout the day or I agree, because this is what Convention 183 says, but recommendation 191 says that all those breaks can be added together and then allow mothers to get to work after the regular working hours or to leave work before their scheduled end of their workday. A very important thing that we need to highlight is if the mother decides to breastfeed while at work, there has to be some conditions in place to combine and protect privacy. And it's not just feeding, it's part of the development of our children. This includes the possibility of mothers not to breastfeed per se, but rather to pump milk, to then refrigerate it, and then go back home and give their breast milk to their child. So the refrigerating conditions have to be in place so that all mothers can access those benefits. And all of that has to be reflected on their labor legislation. Now, to conclude, as I was saying, it is very important to take into account that the objective is to focus on early childhood development. So those 1,000 days after birth where the brain develops to their fullest potential and where feeding is the only way where there is contact with between the newborn and their environment has to take place in the best possible conditions. And now in my final comment is that along the line of rights, there are also international obligations included in the International Code of Marketing of breast milk substitutes that provides for certain prohibitions to prevent promoting breast milk substitutes. With this, I would like to conclude my presentation. Thank you very much. And I am going to stick around in case there's any questions. Thank you so much for your time. Thank you, Ignacio. I see there's already a question on the Q&A section. So if you could please go ahead and respond, and then we can move on. We still have a long ways to go in our region. And now we're going to hear from Audrey about the status in our region in terms of progress in breastfeeding policies and indicators to monitor this situation. Audrey, go ahead, please.
Good morning, everyone. Okay, so I'm going to, as Leo indicated, I'm going to tell you a little bit about what is happening in breastfeeding in the PAHO region. Having heard from Ignacio about what what we can put in place to assist breastfeeding, what is really happening in the region. Let me first remind you, however, of the benefits of breastfeeding. Why do we do this? There are benefits for the child, for the mother, for the family, and for the society as a whole. For the baby, or for the child in the short and the medium term, the child experiences less illnesses. So the non-breastfed baby is at a 17 times more risk of diarrhea, and the child has 6 times more risk of otitis. Breastfeeding, however, prevents 3/4 of hospitalizations that can occur from diarrhea and more than half of hospitalizations from respiratory infections. There's less of a risk of dying. And there is research to support that babies who have been breastfed have a higher IQ, up to 3.44 points higher than babies who were not breastfed, and a better academic performance also. In the long term, it has been found that babies who have been breastfed for longer have more and better work opportunities later in life. So even up to when they have attained the age where they are working, it has been found that there is a positive effect of breastfeeding on income. Later on in life also, there's a 13% lower risk of overweight and obesity and a 35% lower risk of diabetes, type 2 diabetes. For the mother who breastfeeds, there's a lower risk of breast cancer, preventing up to 20,000 deaths per year, and that's globally. 24% less risk of ovarian cancer. There's a lower frequency of obesity and type 2 diabetes, hypertension, and osteoporosis. and it helps the mother to recover her or to lose weight after delivery. Benefits for the family, what are those? Lower expenses. So the money that would be spent on buying formula, bottles, and medical care when the baby becomes ill, that is lower for when there is breastfeeding. The family will therefore have a higher income, less family problems, and it also helps in child spacing. For institutions, when mothers are breastfeeding, there's a better performance and more satisfaction at work, less requests for leave for child illness. So mother would often be asking, my baby is ill, I have to stay home to take care of the baby, or I have to take the child to the doctor. There's less of that when the baby is being breastfed. There's a lower absenteeism and less frequency of extended leave, especially if there's a lactation room. And so overall, there's a better image of the working institution. For the society, benefits are improved income, environmental sustainability. And we need to remember that breast milk is a natural, renewable food and environmentally safe. When formula is being used, that's going to require energy for production and for preparation. And it's estimated that more than 4,000 liters of water are needed for producing 1 kilogram of powdered milk used as breast milk substitutes. So you can see that therefore there's a severe impact on the environment. All right, so I said I'll let you know what's happening in the PAHO countries where breastfeeding is concerned. Looking at the Caribbean countries, first of all, early initiation of breastfeeding. Children breastfed within the first hour of life, which is what we recommend. But for some countries, there's no information because there's not enough surveys being carried out. And that's unfortunate. That's something that we want to improve on in the region. But look at the statistics. So for several of the countries, less than half of babies are experiencing early initiation of breastfeeding within that first hour of life. The most we have, though, for Belize, that is up to 68%, and Jamaica, 65%. So those are the babies being breastfed within the first hour of life. Exclusive breastfeeding, of course, you know by now that we recommend that for the first 6 months of life, babies should be exclusively breastfed, but we find that we are a good way off from that 50% of babies that we want to have exclusively breastfeeding by 2025 and 70% by the year 2030. So, you know, the figures there are very low, ranging from 9% up to 40%. And continued breastfeeding, which we recommend for 2 years and beyond, we find that Haiti, among the Caribbean countries, Haiti is a country where that is happening the most, but that's at 52% of our babies. In Latin American countries, early initiation in Ecuador is up to 72%, and in Colombia, 69%. So those are the highest among those countries. And exclusive breastfeeding for Uruguay, 64% of babies being exclusively breastfed. So of course, they would have met that target that we spoke about for 2025. and surpass that target. So several of the countries there in the Latin American region are doing quite well where that is concerned. And so just on a note, globally, we're at 48% of babies being exclusively breastfed, and we want to get that to 50% by 2025. And it seems that globally we're on track to do that. I would have to also mention what is happening in the countries where it regards the legal status of the International Code of Marketing of Breast Milk Substitutes. Now, we find that in this region, there are several of our countries where there are no legal measures to put in effect the code. So 16 countries have not put the code into effect. And there are 2 countries in the Americas where the code is, where their national laws are substantially aligned with the code, okay? So of the 35 countries, as I was saying, 19 countries have adopted some legal measures. The 2 countries that are fully aligned are Brazil and Panama. Okay. So you can see there that we can say Brazil and Panama are substantially aligned, or their national laws are substantially aligned with the code. Moderately aligned, you have Bolivia, Colombia, Costa Rica, Dominican Republic, El Salvador, Guatemala, Mexico, Peru, and Venezuela. And you see that there are some countries also which have some provisions of the code included, but there are also, as I mentioned, the 16 countries that there is no legal status of the code. We do know that some of these countries are working on laws that will enact the code, and that is something we as PAHO will do our best to assist countries where there are no laws in putting in place laws, and where there are laws where there are gaps. We have to do our best to fill those gaps so that there will be more compliant, more serious laws that will prevent non-compliance with the code. The Baby Friendly Hospital Initiative, that is an initiative, of course, by WHO and UNICEF that seeks to get babies, give babies the best start in life that they can get by the initiation of breastfeeding. So there are efforts by hospitals in many of our countries to make their hospitals baby friendly. We can see, however, that there's a long way to go. So while in Cuba, the statistics are that all their births occur in baby-friendly hospitals and maternity facilities. The next one is Costa Rica, and that's just 53%. Others in the region have a lot of work to catch up in making their facilities baby-friendly so that we can have more babies being born in baby-friendly facilities. Uruguay also at 76% of births taking place in baby-friendly hospitals and maternity facilities. So WHO has really, they have established 9 components to what countries ought to be doing in order to make more of their facilities baby-friendly. There's a need for national leadership and coordination, for policies and professional standards of care, health professional competency building, external assessments, incentives and sanctions, technical assistance, national monitoring, communications and advocacy, and adequate financing. So where you see the green in this chart is where countries the countries have attained the marks where these are concerned. So for example, for national leadership and coordination, 45% of countries have in place a national breastfeeding coordination body that meets regularly. 39%, however, may have in place such a body, or they're on the way to establishing such a body, but they are not fully there yet. Everything for that coordination body is not yet in place. The policies and standards of care, the other policies, so the integration really of the 10 steps into the relevant national policy documents, only 8 or 24% of countries have that. There are, I'm jumping to external assessment. 58% of countries are doing external assessments. 6% maybe they have not done that in a while. So these should be done every 3 to 5 years. Some countries are not as regular as they ought to be, but there are 21% of countries where there are no assessments being done to determine if the hospitals are baby friendly. Okay. So that's just a snapshot of where we are in terms of the implementation of the BFHI. All right, so having looked at all of that, what are the recommendations? Along with WHO and UNICEF, PAHO is calling on governments, donor and civil society, and the private sector to step up efforts to ensure a supportive breastfeeding environment for all working mothers, including those in the informal sector or on temporary contracts, so that these mothers should have access to regular breastfeeding breaks and facilities that enable mothers to continue breastfeeding their children once they return to work. We also advocate for sufficient paid leave for all working parents and caregivers to meet the needs of their young children. So, as Dr. Ibarra said, this includes paid maternity leave for a minimum of 18 weeks, preferably for a period of 6 months or more after birth. And that 6 months, as we know, ties in to the period of exclusive breastfeeding that we constantly promote. We also recommend increased investments in breastfeeding support policies and programs in all settings, including a national policy and program that regulates and promotes public and private sector support to breastfeeding women in the workplace. Finally, in closing, I want to invite you to visit the PAHO campaign website for World Breastfeeding Week. The link is on this slide, but we will post it in the chat for you so that you can be sure to visit the website for more information. Thank you.
Muchas gracias, Audrey, por este resumen.
Thank you very much, Audrey, for summarizing the situation in the region. Obviously, this is one of the topics to promote breastfeeding at work, but it also is related to many other topics, such as regulation, publicity for maternal milk substitutes, and promote friendly breastfeeding, have baby-friendly hospitals. All of these elements are interrelated. And it's also good to see the enthusiasm through the questions that are being posted at the Q&A. Our experts are answering the questions as they are posted. So let us move to the next panel. We will hear about some of the experiences in countries. First, we have Dr. Luz Angela Ochoa from the Ministry of Health and Social Protection of Colombia. You have 10 minutes for your presentations. Thank you very much. Ministry of Health and Social Protection. If we could have it on full screen, please, the presentation.
No sé si ya se está viendo. Perfecto. Primero, muchas gracias.
Thank you very much for inviting the Ministry of Health and Social Protection of Colombia to share our experience with you in this World Breastfeeding Week. So I'm very grateful for that. I am Luz Angela Ochoa. I'm a nutritionist, a specialist in family health. I have a planning for development master, and I work at the nutritional health, food, and beverage at the Ministry of Health. And for several years, I have been at the head of breastfeeding and work. The previous speakers have already showed the situation currently, the indicators and the challenges facing this region and us as a country in Colombia with regards to breastfeeding. As they pointed out, one indicator that has improved recently is breastfeeding in the first hour of life. In 2005, we had 56%, but today, in the most recent survey as to the nutritional situation, which was carried out in 2015, we had reached 70%. That's a significant increase that shows the effort and work carried out by health institutions to encourage breastfeeding in the first hour of life. However, when we look deeper into other indicators, we see that the country has major challenges. Our indicators have decreased from 2005, for instance. It has gone from 46.9 to 36.1. And we speak about challenges and the target that has been set by WHO to achieve 50%. So thinking about the intersectoral work becomes extremely relevant. Talking about breastfeeding, this is not a topic that belongs only to the health sector. We know, and Lancet has demonstrated which are the determinants, and the environment, including the workplace, is crucial if we truly want to ensure rights to children, to the breastfeeding and the mothers also. So there are many factors that play an important role if we truly want to improve our indicators. Now, moving specifically to legal situation in Colombia, we have the substantive code of work with one specific article that means it is mandatory for all employers to grant female workers 2 30-minute breaks in their workday, allowing them to breastfeed without any reductions in their salary. This applies for the first 6 months of the baby's life and goes through to 2 years or even more, protecting the child, protecting the mother in order to continue breastfeeding. And this provides for 1 30-minute break right through the 2 years of age of the child. It is important to point out that if the mother needs to extend these breaks, she can appeal to the health institution to obtain support or medical certification in order to expand or extend her breaks. And this is covered by the health sector and the work sector legislation. In recent years, we have been strengthening laws having to do with protection and care for early childhood. In 2017, Law 1822 extended maternal leave. Every female worker has a 18-week paid leave with this with her salary or the average of the last year. And if if it's a multiple delivery, the woman receives 2 additional weeks, so the 18 jumps to 20 weeks. And also allowing time for the family to prepare for this. There is a pre-delivery leave. It begins about 2 weeks prior to delivery, and this can be enjoyed by the mother, allowing her to prepare for the baby's arrival. Some significant advances have also been made because with the gender approach, it's not only the responsibility of a mother, breastfeeding also includes care for the child's health. And for that reason, paternal leave has also been looked at. In 2002, a father was given 1 week leave, but in 2021, that was increased because men want to participate in these activities at the home. And there is a new line looking into the paternal leave. So Law 2114 was enacted in 2021, increasing progressively the paternal leave, as you can see on this slide. And by next year, it will reach 40 days. But there are major challenges that need to be faced here, because this needs to be appropriate to allow the father to help the mother to participate in all the chores and activities needed at home, so that the mother has time for breastfeeding and can focus on that. In the workplace, or applicable to the workplace, a law was enacted in 2017 providing for breastfeeding rooms in both public and private enterprises. This was an important milestone because we started to speak about a different environment, no longer the health environment, but the workplace, for them to understand how important it is to have the right kind of place for a mother to be able to either breastfeed or express or pump milk and keep it before taking it home to feed the baby. So it's important to explain to the companies the benefits that they can achieve through the implementation of this kind of strategies. We've already seen absenteeism is ensured, less rotation. There is a friendly reincorporation to work after maternal leave, and greater feeling of belonging, because women feel that they are in an environment that is respecting their rights. Furthermore, it gives greater visibility to the company as to its social responsibility. After enactment of the law, the Ministry of Health and Social Protection issued a resolution whereby all the technical specifications are spelled out: hygiene, sanitation, and minimum requirements for the use of these breastfeeding rooms. And what did we want to achieve with this? Well, ensure implementation and monitoring and follow-up. It needs to have the right kind of physical private space, but it also has to be a space that can provide information at work, where a woman spends so much time. She can receive information about the importance of breastfeeding, plus the complementary nutrition. It talks about children's development and vaccination. In other words, women are being educated as to what children are entitled to for their integral development. And we also have a decree that talks about regulating the marketing and publicity of breast milk substitutes and complementary food. So publicity for formula is not to be provided in these friendly rooms. None of that publicity can be shown in the breastfeeding rooms. We are facing an important challenge because the goal is set for 2026. We want to have 600 friendly breastfeeding rooms in the entire country. As of today, there are 414. Some are being readied, others are operational. 397 are already operational. But we want to reach out to more companies to make sure that they implement these breastfeeding rooms, because there is a right for children to have correct nutrition. All the challenges that we've seen in Colombia have focused on intersectorial work. We are convinced that all the work having to do with breastfeeding and child nutrition, including complementary food, has to include different sectors, not only the health sector. And that is why it's important to involve public health in the labor environment. And this has not been easy. It was a real challenge because this is not a topic that business people appreciate. But once they understand the benefits, we have seen a gradual increase in the implementation of these rules. We have identified barriers such as gender inequalities. There are many social and cultural prejudices with regards to public breastfeeding. And this goes hand in hand with the fact that women ought to be able to breastfeed anywhere without being judged. It's also important to address all the marketing practices. Sometimes they don't encourage breastfeeding, but promote formula instead. And the policies and rules need to be reinforced, focusing on family and the protection of children, as this will be reflected in their health and nutrition. Other important challenges are to provide close support to public and private enterprises so that they can understand the benefits of implementing breastfeeding rooms throughout the country. Thank you very much for this opportunity and for recognizing the process that is being developed in Colombia to encourage breastfeeding. And we want to continue learning from you and enjoying your support. Thank you. Thank you very much for sharing your experience with us. And we continue receiving questions. They're being answered gradually also. And moving on with the panel, we will now hear from Mrs. Macarena Alejandra Moya Insulza, who will share with us the experience of the Ministry of Health of Chile. You have the floor.
Ahí se ve bien, ¿cierto? Sí, súper. Entonces, muchas gracias. Buen día a todos y
Thank you very much and good morning to all who are connected. I'm Macarena Moya. I'm a pediatrician, an expert in breastfeeding, and I have a magister in health sciences. And I work on and the interpreter regrets, but the audio from Ms. Macarena Moya is very poor. We'll do the best possible. I don't have any conflict of interest with the industry that produces or distributes baby formulas or food. And I want to protect breastfeeding, just as many of the people connected to this webinar. Breastfeeding does not only require the will, the desire, and an effort by a mother who has just had a baby. It's not only their effort and their dedication, but women who want to breastfeed needed to receive structural support from the government, from society, from families, allowing them to feel that they are well supported and allows them also to breastfeed their baby. As part of this requirement, furthermore, they need breastfeeding friendly work areas. And when women study, they also need this support. So even those spaces where they are studying need to be breastfeeding friendly. This is the most recent publication of Lancet on breastfeeding, on showing the aspects that have to do with public policy, economic, social aspects, and technological advances as an important structural component tied to breastfeeding, together with regulation and marketing of formula. In addition to the general context that covers breastfeeding mothers, we need a context that needs to promote breastfeeding. This includes the health system, family, community, and workplace. But we also have the personal attributes of mothers or the baby that will be breastfed that is going to also have an impact on breastfeeding. And ultimately, all of these factors, all these layers will determine the moment in which breastfeeding begins, its exclusivity, continuance, and this will converge in maternal and child health. And this timeline shows the advances we have had as a country with regard to this topic, where we have seen the breastfeeding protection initiatives. And this is showing it over time. In the 70s, we have the creation of Chilean life of maternal breastfeeding. And then there's an international milestone, which is the creation of the code, creation of the breastfeeding committee of the Society of Pediatrics. We next have the in 1985, the creation of CONALMA, the Commission for the Promotion of Breastfeeding, of which I'll talk a bit more in a moment, and it plays a role even today. More recently, we had the publication of several laws that promote promotion and defense of breastfeeding, and I'll talk more about those also. One of the most recent milestones was in 2022, we began with the pilots for the certification of breastfeeding hospital friendly initiative. And the regional commissions have been implementing this activity, and we are committing to implement the strategy throughout the country this year. When it comes to breastfeeding prevalence, I'd like to share some general data with you of the behavior in recent years of having to do with breastfeeding. Here we have breastfeeding with a prevalence of 68.8% in 2022, and breastfeeding at 3 months and at 6 months at 53.9%. There has been a significant drop after the pandemic, and it's probably still having an impact which is being felt. And we can see for 12 and 24 months, there is a more significant decline.
Entrando de lleno a las iniciativas o este marco normativo.
And now talking about the efforts and national initiatives in Chile around breastfeeding, I don't want to repeat myself, because we've already heard about the International Covenant and the different WHO recommendations, I want to say that in our country, we have had different initiatives that have helped see improvements in our indicators, or at least for the indicators to be maintained over time. One of our most recent ones is Law 2545 from 2011, which revised the rules on maternity protection and incorporates parental postnatal leave. This was a huge improvement because the postnatal leave went from 12 weeks to 24 weeks. And here that is divided into 2 weeks postnatal leave and 12 weeks of postnatal parental leave, which can be up to 18 weeks part-time. And this parental postnatal leave can be transferred to the father. We also have other pieces of legislation that include the right to have breastfeeding time, which is 1 hour a day up to 24 months. We also have maternal protection, which means a mother that has had a baby cannot be fired for until 1 year. We also have the right to medical maternal leave for infants under the age of 1 who are diagnosed with an illness. And we also have the right to a nursery up to 24 months. We believe that this context has had an impact on the good figures we have for breastfeeding at the national level, and which I showed in my previous slide. We also have Law 2869, which passed in 2015, and is about food advertising. This law enables us to have regulatory framework that complies in part with the International Code on Marketing of Breast Milk Substitutes. As a country, we should complement or supplement rather this piece of legislation, but we have done something, but there's still a ways to go. But this bans any kind of advertising of breast milk substitutes, which are defined as initial formulas and continuation formulas up to 12 months old, as provided for in our food sanitary regulations. The law also says that professionals who need to prescribe formulas must ensure that the user has the necessary information in order to appropriately and in an informed way select a formula. In the medical prescription, they should include only the generic name for the formula. That is to say, they may write initial formula or initiation formula or continuation formula, the age of the child, the amount of formula and frequency, but they must abstain from mentioning any specific brand. This also enables the surveillance of an inspection of these items that are provided for in our legislation. The inspectors must ensure that the references are made correctly, but there's also an option for people from the civil sector to report cases. For example, if you go to a pharmacy and you find any kind of non-compliance, for example, some sort of advertising or pressure to buy any specific type of formula, that person may file a refund. Or if there's sales like 2 for 1, if you buy this type of formula, we do have a number for people to report these. We also, the most common one is to advertise formula for children over the age of 12 months old, but with the image of babies are younger, show a younger baby, and makes it confusing for the family. Another thing we have seen around formula are the special formulas, which also have certain that are, for example, for allergies, which we are reviewing to ensure that adjustments may be made or revisions may be made for the legislation. Law 21-155 from 2019 provides for protection measures for breastfeeding. And this is the most specific piece of legislation that we have on breastfeeding. It recognizes the fundamental value of maternity and the right to breastfeeding as the right of the child, as we've heard before, and it enshrines the right of children to access maternal breast milk and the right of the mother to freely breastfeed their child, which ensures the free exercise of breastfeeding and free breastfeeding, and it provides sanctions for any kind of arbitrary discrimination that causes deprivation, disturbance, or threat to these rights. It also says that all people have the right to receive timely, truthful, and understandable information about the initiation, maintenance, and benefits of breastfeeding. This kind of requires us to stay up to date with international codes, because otherwise we would be in non-compliance of this legislation. So we need to be trained so that we are up to date. And finally, we need the families, women, mothers, or breastfeeding women that wish to do so are empowered to make an informed decision in an environment for that decision to be made freely. And the same piece of legislation in Article 18 of our health code says that it is a preferential right of the child to be breastfed directly by their mother unless the doctor prescribes the opposite or the mother chooses not to. And it says that breast is a preferred method for the biological children of their mother. But it also says that any and all mothers may donate breast milk. We do not yet, though, have a national breast milk bank. There's only one available around the national capital metropolitan area. Another aspect that the same law provides for is that in Article 2.1 of Law 2609, that is known as Samudia Law, measures against discrimination, and it says that breastfeeding and maternity cannot be used to discriminate against. This is a well-known picture from 2014, and it is a picture of a woman in California that was breastfeeding their child in California and was told that she needed to cover herself because she was breastfeeding, and she covered her face. And this went viral, but it shows how our society reacts to breastfeeding in public. And this law, like I said, aims at providing breastfeeding in public and other places as well. Another aspect that Law 21-155 adds has to do with the incorporation, the comprehensive protection of women. Chile Grows With You is the name of the program that also interacts with other practices to enable the necessary conditions to be in place in order for breastfeeding to be possible. This includes attending workshops during pregnancy, having a company during labor and delivery, be it through a doula or relative, immediate skin-to-skin contact for at least 30 minutes after birth if the mother and the child's health enable so, as well as indicator monitoring. Specifically, we measure exclusive breastfeeding at the time of discharge from the hospital and from the neonatal unit. Now, in terms of strategies to promote and protect breastfeeding in Chile, well, I have been mentioning them in general throughout my presentation, but one of them is a certification of health care centers that are child and mother friendly. We already have the manual. We launched a pilot program, and like we show here, it's on the pilot stage, but it's the final version of the manual is about to be published. All regions in Chile will be able to participate. Also, all regions have a regional breastfeeding commission, and this regional commission is led by the agency that deals with breastfeeding. We have professionals from the healthcare sector as well as health services and other intersectoral actors, including community actors. And this will lead the certification process for the agencies present in the region. Also, in this certification process, we included both healthcare centers such as hospitals, as well as family healthcare centers. We also have the certification of breastfeeding friendly preschool centers, and certain steps must be followed. So basically, there has to be coordination between preschool centers and the healthcare centers. There has to be a formal commitment with protecting and fostering breastfeeding. Also, to have trained staff at the preschool level, highlighting the benefits of breastfeeding and the specific aspects that need to be taken into account. And also, all these centers must provide for the necessary space in order for the mothers that drop their children off at those centers can continue to breastfeed their child. Now, in terms of human breast milk banks, like I said, we only have one at the time. This is a recent initiative that was born at the Dr. Sotero del Rio Hospital. And for the time being, it's aimed at helping premature babies and babies with a very low birth weight. We also have OWN's mother milk banks called Lactarios, which support breastfeeding. There's a lot that have to do that work with the neonatology units, and they vary in terms of how they work. We also have this document in our lactation rooms, which aim at providing information to the women that opted for breastfeeding and want to continue doing so. This material is included in lactation rooms that can be either within a healthcare centers for, healthcare workers or people that go to those healthcare centers. And this document includes suggestions for, preschools to also have their own lactation rooms in order to provide privacy for the women that want to continue to breastfeed their children. We also have this other document for breastfeeding clinics. They are called lactation clinics. This is a document that's being currently reviewed. It's being reviewed and revised. We currently have the old version. This is a technical document that aimed at healthcare professionals that provide advice, and we want to broaden the many options that our healthcare workers at the primary healthcare level have. Finally, in terms of how they operate, we have national breastfeeding or lactation reference centers. We have 2 undersecretaries. Then in each undersecretariat, we have a national like benchmarking or reference centers. We also have our ministerial task force for breastfeeding that includes different actors within the ministry that work on this. And this has enabled us to make this component cross-cutting. And this task force enables all ministerial reference centers to send consistent messages so that we can all protect, promote, and work for the same objectives.
We also have the National Lactation Commission, known by CONALMA. It is a consultative agency having to do with maternal breastfeeding based on experience, the best available scientific evidence, and it has no conflicts of interest. Furthermore, it wants to be a bridge between the health team and the community, because there are also members who are part of civil society through foundations, for instance, in support of breastfeeding and NGOs. Lastly, we have an intersectoral task force, the HIALMA, which is the kindergarten initiative that we are carrying out with the education sector that allows us to provide continuity for the strategy. We also have a web page making available all the technical documents, the minutes of meetings, and other information for professionals. To conclude, as we have seen in the Lancet, human breast milk is that not only a perfectly adapted nutritional supply for the infant, but probably the most specific personalized medicine that he or she is likely to receive, given at a time when gene expression is being fine-tuned for life. This is an opportunity for health imprinting that should not be missed. Thus, breastfeeding continues to be an opportunity to reinforce well-being and health, not only of the children, but also the breastfeeding mothers, the family, and of society overall. Thank you very much for your attention. Thank you very much for this interesting presentation, and congratulations for all the advances made in Chile in this area of breastfeeding protection. It's also very important to ensure there is surveillance of action. And if there are no laws, or if laws are weak, the population and civil society groups actually have to demand and advocate for the enactment of such laws. So now we're going to hear from someone representing civil society who will be talking about the activity, the role of advocacy and of NGOs. This is Alison Bernard of the Breastfeeding and Child Nutrition Foundation of Barbados and the Health Caribbean Coalition. So let us hear from Dr. Alison Bernard.
Good morning. Thank you.
Good morning.
Let me just share screen. So
yes,
good morning.
we can see your screen now. So please go ahead with full screen presentation mode. Yes.
This is full screen.
Okay, this is okay. Thank you.
Yeah. Okay. So good morning, everyone, and happy World Breastfeeding Week 2023. So my name is Dr. Alison Bernard, and I am a pediatrician, and I'm also a public health professional and a breastfeeding counselor, and I'm also the executive director of the Breastfeeding and Child Nutrition Foundation. Further, from here on, I'll call the BCNF. So I've been charged this morning with giving you a snapshot of the work that the BCNF is doing to support advocacy for breastfeeding in my country. So I'm going to start off with the local breastfeeding context. You know, what are we doing with breastfeeding here in Barbados? Then some of the challenges that we experience in terms of advocating for breastfeeding here. We then going to look at breastfeeding advocacy principle interventions. And then we're going to shine a spotlight specifically on breastfeeding workplace policy, some of the key elements as it relates to the theme for World Breastfeeding Week this year, and PAHO's theme. We're then going to look at the broader advocacy issues and how we are addressing them, and then some of the lessons learned. So this is a local breastfeeding context in Barbados. Right now, well, as of 2012, this is an old statistic, 19.7% of our mothers exclusively breastfeed. This is one of the lower rates, but there are countries in the region who are a bit lower. And of course, we are far away from the WHO or WHA target for 2025, which is at least 50%. The average age of cessation of breastfeeding for the mums in our country, this is again the 2012 statistic, is 8 months. And that we carried out, the BCNF would have carried out a survey in collaboration with the University of the West Indies. And the results from that survey suggested that 40% of mothers stopped exclusively breastfeeding because they had to return to work or to school. So of course, underlining the point that being made here for the theme this year and PAHO's theme in terms of making, creating a breastfeeding environment for mothers in this country to support them in maintaining breastfeeding for as long as they choose to. Barbados only adopts voluntary compliance of the International Code of Marketing of Breast Milk Substitutes. And in 2017, our local hospital, the Queen Elizabeth Hospital, would have received accreditation from UNICEF for baby-friendly hospital. And we're currently seeking re-accreditation. In Barbados, there's short maternity leave, not making the Convention 183 for the ILO Convention 183 of 14 weeks. We only have 12 weeks maternity leave. There's no paternity leave. We have no breastfeeding workplace policy legislated, although individual organizations choose to, and some choose to implement or introduce interventions as it relates to breastfeeding workplace policy. We have very few designated public spaces for breastfeeding or for breast pumping. So the challenges of breastfeeding advocacy in Barbados. We're a small society, we're a small island developing state, and Barbados in particular, maybe 280,000 population, and we're 166 square miles. So we have, and because we're a SIDS, we also have a unique perspective in terms of advocacy. We have a small pool of available financial resources. There are a few charities, and the majority of them go to the same funders and the same donors for their financial resources. We also have a very small volunteer pool. So it makes it very difficult to sustain advocacy and support for breastfeeding in Barbados. We also have potentially have issues around conflicts of interest with the code because we adhere to the International Code of Marketing of Breast Milk Substitutes. It means that we take an ethical stance, and therefore we do not go to any and all donors or funders for our financial needs. Again, further constraining the pool of support that we can access. So there are also ingrained sociocultural norms. For example, things like breastfeeding makes breast sag, which can be a deterrent for some moms in terms of initiating breastfeeding. The sexualization of breasts, a preponderance of single parent households, and absence of the extended family, or the reduction of the extended family in Barbados over the years, making it difficult for moms to have that support system in their household and in their immediate circle to help them to maintain breastfeeding. There is the thinking that breast milk is not adequate to sustain nutrition in infants, and there's also the use of prelactial feeds. And then there's also the stigma associated with breastfeeding, not to the extent that you will see in more developed countries, but certainly over the last 10 years, we have seen an increase in mothers highlighting that they have been harassed in some way in terms of breastfeeding in public spaces. There's also the lack of political will for needed policy creation and implementation. For example, the international code, as I said, we adopt voluntary compliance. But the thing is that unless we fully enact this law, there is, well, certainly countries that fully enact the laws we've seen in previous presentations, they have increased breastfeeding rates. And there's also a lack of available current local and regional research to inform and influence our projects and programs. If we're still relying on data from 10, 12, 15 years ago, it's very difficult to move forward if we don't know where we currently are. I forgot to mention above that in the previous slide that although our breastfeeding rate was 19.7% in 2012, we would have done some research with the University of West Indies, as I mentioned, and that rate, when we checked it, was 12.5%. So it dropped from 19.7 to 12.5 in the preceding 4 years. So just going to talk a little bit about breastfeeding advocacy and principal intervention. So the BCNF takes a two-pronged approach to the intervention. We look at it from, I guess you could call it grassroots or individual perspective, where we have a peer support training program that we've developed, currently seeking funding for, but we acknowledge that our resources, our human resources are limited. And in order for us to be able to support our mothers in breastfeeding, we need to have more feet on the ground. So we developed our own peer support training program, and that in that way, that will help build capacity internally within the organization and therefore help to be able to support mothers better here in Barbados. We have in-person and virtual support groups. The virtual support group came out of COVID, and that is still thriving despite the fact that we're, as we say here in Barbados, we're all outside now. But because it does maintain a certain level of intimacy and confidentiality that some of our moms like when they're discussing their specific issues, and not just around breastfeeding. We also have an in-person support group that we just recently got funded. And that helps to build community. All of it helps to build community. Everything that I'm talking about now helps to build community for the mothers in our environment, and build that support that they need. We have breastfeeding classes, and we do one-on-one consultations with mothers as well. And we every year we do a lot of community outreach. So on the societal level, we would have developed back in 2018 with the help of funding from the Caribbean Development Bank and facilitated by Healthy Caribbean Coalition, who we are associate members of their NCD Alliance. We received funding for developing breastfeeding workplace policy guidance. That was nationally recognized, and subsequently it has been enshrined in our national workplace wellness policy. I've been told by stakeholders recently that this national workplace policy is now being implemented, and the hope is that baby-friendly workplace interventions are soon going to be rolled out, well, in the near future. We're really excited and looking forward to see what that looks like. And then, of course, there's the international code implementation. From our perspective, because we're a small organization, we do a lot of sensitization, because many persons in Barbados don't know anything about the international, I mean on a national level, Joe Public. And so what we do is we try to give them the information that often their decisions in terms of their nutrition choices are not necessarily impartial, that there are influences from industry. And so in that way, we help to sensitize them and make them aware and hopefully inform their nutrition choices. Then as well, we also were a part of a baby food project along with the Healthy Caribbean Coalition, where the project was around establishing developing a base, an information base of commercial baby products, determining the amount of salt, fat, and sugar in these products, and then also informing policy and bringing awareness to the importance of breastfeeding and complementary feeding, and bringing awareness to what the WHO guidelines around these practices are. So I just wanted to give a brief spotlight on, this was discussed in previous presentations about what are the elements of breastfeeding workplace policy. And so certainly this is what has been included in the guidance that we provided to the Ministry of Labor, Social Security, and the third sector here in Barbados. So flexible working hours, whether, as was previously mentioned, is that a shortened workday? Or is that fewer days in the week where mom comes into work? We learned a lot from COVID-19 and the pandemic, and recognizing that flexible working hours work, and it certainly can work for breastfeeding mothers. And in lieu of extended maternity leave, although extended maternity leave, in my opinion, is the ideal scenario, until that eventually occurs, providing moms with a flexible working hours can also do a lot to help her continue or maintain breastfeeding after she returns from maternity leave. It can help her, as we mentioned before, psychologically, and the benefits, as we know, to the employer and to all the staff in the organization is well known. Also, paid breastfeeding pumping breaks. I think someone mentioned at least one paid pump break. We're saying at least 2 pump breaks throughout the day in a safe, hygienic space. Some of our moms would have expressed to us that they often do not continue breast pumping because they have to do it in their organization's bathrooms. As you can imagine, that is not a hygienic space to pump your breast milk in. It's not something that we encourage. And so providing moms the bare minimum, a clean space for them to be able to pump their milk is, I think, is at least what you should do, employers could do. Providing adequate storage for breast milk is also one of the key elements that we discussed. And then access to nursery services, as was discussed. Whether it is that moms are allowed to leave the office and go to the nursery to breastfeed their babies or to take pumped breast milk, these are all elements that are, we think, important for breastfeeding workplace policy. This is not an exhaustive list. So just some recommendations, having done that work on breastfeeding workplace policy. And I think because often moms in these environments feel terribly marginalized, they often mention that they have to go to their employers, even though their employers would have known that they're on maternity leave. They have to go to them to say, hey, I'm coming back. I need a space to pump my milk. And okay, so that is the status quo right now. But what we're saying is that if we can sensitize from the top, upper management, this is the benefit to this mom. This is the benefit to you as an employer, as mentioned previously, all the benefits in terms of lower health insurance claims, less absenteeism. It's a great PR marketing tool as well. And then obviously the benefits to mom, psychologically, emotionally, the health, mom's health as well, and the health of baby. And then, and we're talking about top down. So upper management initially, getting them to buy into the idea of the breastfeeding workplace policy. And then, of course, the education and sensitization of all staff as a priority. I remember going into an organization to sensitize on this policy, workplace policy, and a number of the staff basically looked at me with glazed eyes because, in essence, they couldn't understand what the need was for this type of policy in the workplace. Moms have breasts, just breastfeed your babies. That was the general consensus or feel from that sensitization session. And also, an important thing here, policy needs to be translated into legislation, just like with the international code. In 2018, when we would have presented our guidance on a national forum, the consensus was employers should just do the right thing. And that was 2018, it's 2023, 5 years later. Some employers have, very few, but some have. But for those who haven't, there needs to be some recourse that can be taken, because mothers deserve to have breastfeeding workplace policy. They deserve to have clean spaces. They deserve to have the time to pump. So it can't be some get the benefit of it and others don't. So legislation would certainly help to distribute that advantage across the board. And so we're asking for legislation on breastfeeding workplace policy. It would mean then greater enforcement and greater implementation. And then, of course, there are just a few, just really quickly, broader advocacy issues. The presentation is not that long. Establishing credibility as a small non-governmental organization who is basically, relatively speaking, new on the scene, means visibility and being seen as an organization who uses evidence-based information, who can be relied on to provide the support that mothers need in an environment. But all of that requires support, financial support in the main, in order to be able to meet that high standard and be able to provide that service to the mothers in our environment. But visibility is important for our credibility. So the BCNF has social media management, and we are seeing an increase in the numbers of persons who are accessing our service as a result of being more available and accessible on Instagram and Facebook. We also have a podcast where it's called The Milk of the Matter, and it essentially provides a voice to mothers and families who these topics are not being discussed, certainly not in Barbados, and I don't think on a regional level. The difficulties women have returning to work, the challenges that they experience, the psychological impact of it, things like postnatal depression. We're not having those conversations. Mums at the moment, in my opinion, don't have that voice. So the BCNF has created a platform for mums, families, and experts in the field who can assist in discussion to have that voice and to bring more clarity and awareness to a national audience about these issues. And then, of course, I don't think any NGO will dispute this. Human and financial resources, limited. We have that in limited. We have a limited capacity there, but the BCNF has tried to mitigate the challenges there by putting in human resource policies and procedures so that we are able to maintain efficient human resource management activities in terms of bringing volunteers into the organization and maintaining or retaining these volunteers as much as we possibly can. The challenge that we have there, of course, is that the volunteer pool is small, but not just that, there's a rapid turnover of the staff. So that makes it very difficult in terms of being able to do the work that we want to do. And then, of course, financial resources. The BCNF looks at funding, grant opportunities. We do our own fundraising. So there are lots of ways that the BCNF brings funds into the organization. Still very, very challenging because, of course, as I mentioned before, apart from going to international bodies, local organizations as well want to give, but they have a certain amount of funds, and most of the organizations go to the same, most of the NGOs go to the same organizations, limiting the funding that each organization tends to get. So the lessons learned here. The lessons learned after 9 years as a non-governmental organization here in Barbados, the importance of building networks. It's totally counterproductive to operate in a silo. If you can find organizations aligned to your objectives and your mandates and partner with them, like we partner with the Healthy Caribbean Coalition and the Barbados Childhood Obesity Prevention Coalition, etc., that we then work with PAHO and UNICEF. It makes and other organizations, it makes the work it's not difficult, but it makes it easier to achieve your agenda if you're working in line with other organizations as well, especially if you're a small one like ours with limited resources. It certainly makes it a lot easier. And one of the other things that I'm very proud of in terms of the coalition building, the BCNF is part of a regional breastfeeding coalition, along with the Breastfeeding Association of Trinidad and Tobago, who I believe is on in this meeting as well. Mrs. Rosemary Anatol, and as well as persons from Belize, as well as from Antigua and from Aruba, Manouche and Janelle in those countries. And we formed a coalition recognizing that we are more powerful as a voice together as opposed to separate. But this requires funding. Again, we each have our own organizations to run. And in order for us to come together as a coalition with a similar agenda, moving forward towards a goal still requires some level of support, not just financial, operational support, policy support, anything that we can get assistance with will help us move forward this coalition, and this will be beneficial to all the mums and the families in the region. And we've also learned that the importance of building strong relationships with ministries, the Ministry of Health and Wellness, Ministry of Labor. We've also done work, our podcast is in collaboration with our Ministry of Education. So linking with these organizations and linking with their agenda helps to move forward us achieving our objectives. And of course, the need for effective resource mobilization and marketing for the growth and sustainability of their organizations and all the different things that we do as an organization in terms of newspaper columns, podcasts, and our own individual fundraising as well. So it's not all doom and gloom. Advocacy in the region is challenging because of the size of our individual countries, the size of our various organizations. But despite that, with limited resources, certainly the BCNF, and I know my other colleagues in the other countries, have managed to do a lot with very little. We have a volunteer support that, as I said, is very, very, not nebulous, but it's very, very challenging because most of our work is based on the work of volunteers. It can be very, very difficult to sustain, but we've managed to do it regardless. And so this is just a slide of some of the work that the BCNF has managed to do. So we can see the draft breastfeeding workplace policy guidance articles in our newspapers, virtual breastfeeding classes, and our support groups. And these are just images of the podcasts that we would have and that we're releasing actually this month for World Breastfeeding Week. And then these are some of the mums and babies in our in-person breastfeeding support group. And just one final thing that I wanted to say, and this is endorsed by the Breastfeeding Coalition, the Regional Breastfeeding Coalition that I'm a part of. NGOs' ongoing advocacy ensures breastfeeding remains a priority in all areas of discussion with a focus on the needs of breastfeeding mothers and their families. We need to improve support for NGOs who do this invaluable work, and that is essential. And I just want to say thank you for the opportunity to share some of the work that we're doing in terms of advocacy in Barbados.
Thank you very much, and thank you for presenting this important work and the important role of civil society in putting pressure and protecting breastfeeding, especially for working women, but also in general. We are already running out of time, but I would like to mention that there are many resources available, so please open the link as well in the chat. Que abran también el vínculo en el chat donde hay muchos nuevos documentos.
Open the link in the chat where many new documents have been posted, especially on the child-friendly hospital initiative. All of this has been recently translated into Spanish and made available to you on our webpage. Furthermore, there are follow-up and monitoring reports of the International Code for Breast Milk Substitute. There is information from several countries, plus tools allowing follow-up of the code. We don't really have any remaining time. Hopefully, most of the questions have been answered already in the Q&A or chat. But if you still have any questions, don't hesitate in writing to us. Let me also say that a lot of progress has been noted, but we're still far from the 18 weeks or preferably more than 6 months of paid maternal leave. Also, paid time or breaks to express milk or breastfeed at work, because women ought not to have to make a choice between breastfeeding their babies or work. Many countries have made strides, which is very positive. And we're also seeing advances in other areas. We have had over 500 people connected to this webinar. That is the maximum capacity available to us with Zoom. So unfortunately, not everyone was able to connect, but all people who registered for this webinar will be sent a link. And on the website, you'll be able to find that link, and that will be available to everyone, both those who joined the webinar and those who were unable to connect. I would like to thank each and every one of you for connecting and for your questions, and obviously the panelists and the interpreters. And we wish you great success in all your efforts to promote and protect maternal breastfeeding. We can also send a certificate to all the people who have remained connected at least for 1 hour, and a recording will be sent to all the people who registered. It might delay 1 or 2 days to get it all out, but you will be receiving it. This being said, we're going to end today's webinar. PAHO will continue providing support to all your efforts to promote breastfeeding. We thank you very much for your interest and your participation. Goodbye.